this video, we're going to have a look at whether using psychiatric diagnoses by psychologists, counsellors and psychotherapists is helpful or unhelpful. I'm going to use the general term therapy and therapists throughout this video to represent the work of psychologists, counsellors and psychotherapists to save having to list all three every time. The disagreement between the medical model and contextual therapists stems from different core beliefs and different theories of knowledge. The different rules and aims that have been generated have also resulted in different practices. So both sides are talking about the same clinical events, but they disagree about what they mean. This is an issue that stems way back into history, and Kuhn in 1962 described this as the paradigm clash. So let's look at the therapy model first. This is contextualist. It assumes the need to explore the context of the past and present to understand events and psychological phenomena. It operates the utility principle, which makes the assumption that theories should be practically useful and help address the problems. It sees causation as a multifaceted, multidirectional, relational and nonlinear process. Explanations are sought at the level of ultimate causation, i.e., why. Now let's look at the medical model of psychiatry. Psychiatry is reductionist. It assumes psychological phenomena can be reduced to and understood solely in terms of neurological processes. It is mechanistic, which is a circular assumption that assumes because the description of events, the label, matches the events being described, the symptoms, this is taken as proof of truth of their theory. Causation is directly linked in space and time to the observed effects. And finally, explanations are sought at the proximal level of causation, i.e. how. Let's look at what diagnoses do. One of the things they do is they describe, but they don't address issues of how symptoms developed or how to change. They do enable clinicians to communicate with each other, thus serving the needs of clinicians and not necessarily or primarily the needs of clients. Diagnoses create an all or nothing dichotomy between sick and well. People either have a diagnosis or they don't. Another problem for diagnoses is that clients can become dependent on them, and this can become an obstacle to recovery, although this is not always the case. The issue of causation is very important. In psychiatry, the assumption is that all psychological phenomena can be understood in terms of bioneurological processes, with the latter causing the former. Contextualists, on the other hand, assume that if certain phenomena consistently occur together, this does not mean that one causes the other. It can only be said that they are in relation to each other. Psychiatry, or the medical model, assumes the unidirectional causation in time and space, where bioneurological causes are directly linked to the observed effects. A causes B. This leads to the assumption that brain causes thoughts and actions, therefore, understand the brain to understand thoughts and actions. And further, observing disturbed behaviours enables the identification and isolation of the causal bioneurological events. The main problems with psychiatrists' view of causation is that even a full understanding of neurology can't explain why or in what context thoughts and actions occur, only how. It is a circular argument to suggest that diagnostic labels explain the symptoms from which the labels were originally inferred in the first place. For example, schizophrenia does not cause delusions, but delusions may cause someone to get diagnosed with schizophrenia. The diagnostic categories themselves are actually quite arbitrary. They do not have unique symptoms. The same symptoms are found in many different categories, and comorbidity is common. It is also a well-known phenomenon that psychiatrists and other clinicians diagnosing the same patient can often come to different diagnostic conclusions. The model of causation in therapy, we have contextualism replacing A causes B with A is in relation to B. This does not require a diagnostic category as an intervening variable between A and B. It assumes that certain thoughts or actions could be related to neurological dysfunction, but equally they could be related to different environmental and contextual factors. The therapy model of causation assumes that it is an illusion that people can be removed from their environmental context, so it is impossible and pointless to try to examine neurology in isolation. There are some problems for therapists though, because seeking contextual explanations runs counter to the medical model preferred by Western society, which has a strong tradition of locating causation or fault within the individual. The therapy model prefers living with ambiguity and not knowing, and with the possibility of multiple meanings, and this runs counter to the dominant medical model's belief in objective science that can lead to discovery of irrefutable truths. There are three main ways that diagnostic categories are considered to be unhelpful to clients. Diagnoses do not help reduce the power imbalance between clinicians and clients. They do not enable clients to find their own voice and define themselves in their own terms. And lastly, diagnoses impose external values and assumptions on clients. There are some definite benefits, though, of diagnostic categories. They enable communication between clinicians, specifically those working within the medical model. Some clients value being diagnosed and experience it as helpful in terms of trying to understand their experiences. For clients with more severe and chronically enduring mental illness that require hospitalizations and ongoing medication, the language of diagnoses is actually important. So, in summary, and with a tentative conclusion, the use of diagnostic categories does not need to be an either-or question. They can be used and not used depending on the context. Therapists can work and communicate with clients and other contextualists at the relational and ultimate level of explanation to explore why and in what circumstances phenomena occur, and then work and communicate with the medical model clinicians at the proximal level descriptions of how. In this way, the contextualist therapists can live with the ambiguity of moving in and out of the different theoretical worlds, forming a bridge between them to assist clients on the road to recovery.